Welcome to This Explainer. Today, we are jumping right into a rigorous academic masterclass exploring clinical dermatology notes from Tikri University College of Medicine. Our sole focus, psoriasis. We're going to map this journey from the intricate microscopic cellular mechanisms driving the disease all the way out to macroscopic patient management and complex clinical protocols. It's a brilliant, highly detailed look at a condition affecting millions, and we're going to break it all down systematically. Let's get into it. Okay, here's our syllabus for today. We'll be hitting 5 key areas: definition and epidemiology, pathogenesis and genetics, histology, clinical patterns, and finally, treatment protocols.
Section 1, Definition and Epidemiology. Let's establish our academic baseline and see exactly what we're dealing with.
So, formally speaking, psoriasis is a chronic, non-infectious, inflammatory skin disorder. Now, in dermatology, precision is absolutely everything. The visual hallmarks you need to look out for are well-defined salmon pink plaques bearing large, adherent, silvery, centrally attached scales. That specific contrast, the salmon pink base sitting underneath a prominent silvery scale, is the classic clinical presentation you really need to visualize.
From an epidemiological standpoint, we are looking at a prevalence of about 1 to 3% in most populations. That means millions of people are impacted globally. Interestingly, though, it's quite uncommon in American Black populations and almost non-existent in Native Americans. It is a highly unpredictable chronic condition. It's characterized by these unexpected exacerbations and remissions, and honestly, about 50% of patients will experience a spontaneous remission at some point without any clear explanation.
Moving to Section 2. Pathogenesis and genetics. Let's zoom into the cellular level to understand what's actually driving this.
While the exact initial spark is unknown, the pathogenesis here is essentially a relentless feedback loop. It's a true vicious cycle between two main players. On one side, you have the hyperproliferation of keratinocytes. Those are the primary cells of your epidermis. On the other side, there's an inflammatory cell infiltrate, primarily driven by neutrophils, TNF, and Th17 T cells. These two abnormalities literally feed off each other, locking the skin tissue into a constant, hyperactive state of cell division and chronic inflammation.
To really put that aggressive speed into perspective, just compare it to healthy skin biology. Normal epidermal kinetics, cell turnover takes about 30 to 60 days, with roughly 30% of the basal cells actively dividing. But in psoriatic kinetics, that turnover time plummets to less than 10 days. The growth fraction of active basal cells absolutely skyrockets to almost 100%. The skin is literally producing cells way too fast to shed them normally, and that is exactly why those thick, silvery scales build up.
So what kicks this whole cycle off? Usually, a genetic predisposition gets suddenly activated by specific environmental triggers. It's polygenic. If both parents are affected, a child has a massive 50% risk. We even know the specific locus. PSORS1 accounts for half of that genetic susceptibility. And if a patient has the HLA-CW6 genotype, they're looking at a 20 times higher risk. But the triggers themselves are fascinating. Physical trauma to the skin can induce lesions, which is known clinically as the Koebner phenomenon. Infections, notably a strep tonsillitis infection, frequently trigger a specific variant called gut-hit psoriasis. Even things like stress, certain drugs, smoking, and alcohol can suddenly ignite this genetic powder keg.
All right, Section 3, Histology. Let's examine the key pathological signs you'd actually see under a microscope.
It is absolutely fascinating how microscopic tissue architecture directly dictates what the patient experiences. Because the cells rush to the surface so fast, they don't even have time to lose their nuclei, a condition we call parakeratosis. You'll also see Munro microabscesses, which are these tiny infiltrates of white blood cells right in the epidermis. But pay close attention to Auspitz's sign. If a patient scratches off a scale, it instantly bleeds. Why? Because histologically, there is irregular epidermal thickening, but it becomes incredibly thin right over the dermal papillae, where these dilated capillary loops sit. You scratch the scale, you hit the capillary, and boom, pinpoint bleeding.
Next up, Section 4, Clinical Patterns. Transitioning from the microscope into the exam room, how does this actually manifest? Well, psoriasis isn't just one thing. We can break it down into several distinct taxonomies. The plaque pattern is your most common, those symmetrical spots on the elbows, knees, and lower back. But contrast that with good date psoriasis. Good date means drop-shaped, and it appears suddenly as numerous small macules, usually in kids, right after strep infection. Then we have flexural psoriasis, found in the skin folds. Interestingly, this type is glistening red and entirely lacks those trademark scales.
On the extreme end of the spectrum is erythrodermic psoriasis, a rare, severe form where the skin is universally red, often accompanied by intense shivering and malaise. And don't forget the nails. You'll often see classic signs like thimble pitting or onycholysis, where the nail physically separates from the bed.
But remember, we are not just dealing with a superficial skin problem here. This is systemic. Between 5 and 20% of cases develop psoriatic arthritis. This often targets the distal terminal interphalangeal joints, the ones right near the fingertips, especially if the patient has significant nail changes. Now, this can easily mimic rheumatoid arthritis, but clinically, the rheumatoid factor blood test will come back negative. There's also a strong correlation with the HLA-B27 gene when the spine gets involved. Because it mimics so many other diseases, our rigorous differential diagnosis is crucial. You have to definitively rule out things like discoid eczema, secondary syphilis, or fungal infections like tinea.
Finally, Section 5, Treatment Protocols. Let's look at how we actually manage the patient systemically.
Before we even talk about drugs, we need to ground all this academic theory in a stark clinical reality. This right here is the guiding principle of psoriasis management. At present, there is no cure. All treatments are suppressive. Treatment must never be more troublesome than the disease itself. It is a constant, incredibly delicate balancing act for the physician. Because of that reality, we follow a very strict escalation of care. We systematically step up the intensity based on disease severity. We start with localized topicals, move up to light-based phototherapy, and we only reserve systemics and biologicals for extensive refractory disease.
So, breaking down those early steps, step 1 includes vitamin D analogs, like calcipotriol, which are great for mild disease. You've also got corticosteroids. They are a mainstay, but you have to watch out for dermal atrophy, literally a thinning of the skin. There's also coal tar and dithranol. They're highly effective, but notoriously messy. If those fail, we move to step 2, phototherapy. We typically use narrowband UVB. There's also Puva, which combines a drug called asoralin with UVA light. But there's a huge catch with Puva. The patient has to wear UV-blocking glasses for a full 24 hours post-treatment just to prevent cataracts from forming.
Now, if the disease covers more than 20% of the body surface area or is severely impacting quality of life, we step up to step 3. These are the heavy hitters. Systemic retinoids, like acitretin, are great for pustular variants. Antimetabolites, like methotrexate, inhibit cell division but require incredibly strict hepatic monitoring because of liver fibrosis risks. You've got immunosuppressants like cyclosporin to calm the system down. And finally, biologicals, like the anti-TNF-alpha drug etanercept, which are immensely effective but highly expensive.
But here is where academic rigor meets a severe clinical warning. Both acitretin and methotrexate are highly teratogenic. That means they can cause severe birth defects. This isn't just a suggestion. Strict contraception protocols must be followed. With acitretin, for example, a patient cannot donate blood for 2 full years after treatment. The physiological impact of these systemic drugs is massive.
Which brings us to the end of our explainer and leaves us with a pretty heavy question. Knowing that these treatments can cause things like liver scarring, immunosuppression, or even severe birth defects, how do clinicians actually successfully balance a patient's daily quality of life against the profound life-altering risks of these interventions? It really highlights the immense ethical and clinical complexities of chronic disease management. Thanks so much for diving into this academic masterclass with me, and I hope it leaves you reflecting on the delicate balance of medical science.